PAP flap reconstruction, which is where we take the thigh tissue and we transplant it to the chest to reconstruct the breast. The risks of that surgery, other than the general risk of bleeding, infection, and complications, there's a risk of flap failure. The risk of flap failure is less than 1%. When you wake up, you're in the ICU for a few days. You're wide awake, you're not sick or anything. It's just for monitoring purposes. And the way we monitor it is skin from the thigh is actually going to be left on the outside. It's sutured in. It's what's called a skin paddle. And there's a probe that sits on the outside of it that measures your tissue oxygenation. If there's any change in the tissue oxygenation, if there's an arterial issue or a venous issue, that probe is wirelessly communicates with our cell phones and also with the nurses in the ICU, and will alert us that there's an issue. And about 7% of the time, we have to take you back to the operating room to take a look and see what's going on. If there's an issue that the artery is being compressed or twisted or something. The failure rate is less than 1%, which is very low because we're able to monitor this so closely. And about 95% of these issues occur within the first 48 hours. You're in the ICU for 2 to 3 days for monitoring purposes. I'm not worried about symmetry at this stage. Basically, the goal is to get the tissue up, get it to survive. Sometimes you'll have asymmetries or irregularities. That's something we would deal with at the second stage. There is a risk of fluid collections, of hematoma. Those are the general risks of any procedure. With the thigh, you're going to have something called Profunda dressing on, which is this suction dressing covered with like a saran wrap that's on for about a week. You go home with that and you can shower with that. And that dramatically increases the healing of the thigh. There is a risk of wound complications with the thigh. It takes a while for it to heal. Risk of adverse scarring. The risk of scarring is 100%. We tell everyone that's the only thing we guarantee you about the scars that you're going to have them, but we're going to do everything we can to try and minimize the appearance of it. Usually about 6 months after the surgery, we'll take you back to the operating room as an outpatient, and that's where the breasts get reshaped. Sometimes we'll take fat and graft it in to make them fuller. Sometimes we do liposuction to make them smaller. If any reconstruction with the nipple, sometimes we'll have to do that as well. There's a risk of something called fat necrosis, where the flap itself survives, but you can get areas of firmness due to sometimes the areas of the fat aren't happy with the amount of blood supply they have, so they'll get firm. And at the second stage, we'll go and we'll take that out, and if we have to, we can fill it in or fat graft. There's also the risk of clots in the legs. If you notice any swelling in one leg or both legs, often it's in one leg, clots that go to the lung, which is called the pulmonary embolus. If you notice any acute onset of shortness of breath, very uncommon when you're on the blood thinner that you'll be on when you go home and when you're in the hospital. But if you notice anything, you just gotta let us know. But there is the risk of that. Lastly is the risk of scarring. The risk of scarring is 100%. You'll have scars on the thighs. You'll have scars on the breast, but with the breast, I'm not very concerned about the scars, because at the second stage, we're going to remove the skin panels and revise the scars.